Good evening, everyone. Welcome. It's lovely to see you all here tonight, and especially the 38 or 40 people we've got joining on Teams as well. So it's a very busy evening. Before we start the whole talk, we've got Jill, who's the Chief Officer from our Derby charity for the University Hospitals of Derby and Burton. It's a big mouthful. So Jill, if you'd like to say a few words. It's lovely. Thank you. Brilliant. Thank you.
Hello everyone, as Val says, I'm Jill Matthews. I head up Derby and Burton Hospitals charity, and I just want to spend a couple of minutes today telling you a bit about what the charity does for our patients and staff here at UHDB before you get to the main event, which is I know what you're all here for. So our charity exists and has existed for nearly 35 years to support the patients, the staff and our families here across our hospitals. So we support work here at the Royal Derby, at Florence Nightingale on London Road, but also at Queen's Hospital Burton, Samuel Johnson in Lichfield and Robert Peel in Tamworth, and some services out in the communities of Long Eaton, Heanor, Ripley, Ashbourne and Ilkeston. So we cover quite a big reach. And the sorts of things we do, so we do a lot of work to support our patients to make our environment better for them. So if you ever spend any time in the hospital, you'll probably see artwork on the walls. We have some in here, things like the badgers downstairs made of wicker. They're all provided by the charity to try and make the environment feel more welcoming, to help patients find their way around the hospital, because it's complex, shall we say. But then we also fund a lot of equipment. So we do provide about £1 million worth of equipment every year into the hospital, and make sure that we are providing some cutting edge research, so that not only are we doing great things today, but we're trying to help make healthcare better for the future. And I know we've got a lot of service users in today, and one of the things we do like to do for our patients, and I suggest you have a think about if it's useful to you, is we fund a lot of support groups. So where our clinical staff want our patients to have patient groups where they can meet outside of the hospital, to share experiences, to have talks from professionals, the charity is quite willing and able to support those sorts of events by funding room hire and guest speakers. So if that's something that might be of interest to anyone, please talk to professionals within UHDB or to myself, and we'll make sure we share our contact details, because if I can help, I will. And then the other main piece of work we do, as well as supporting our patients, is supporting our staff, who work incredibly hard day in, day out to provide the services across all our sites. So we do some very simple things, like we fund lots of wellbeing activities. Throughout winter, all of our staff can have access to free tea and coffee, which we hope is a small thank you for their hard work, and recognises how difficult it is sometimes to get a break on a ward or in an outpatients department. And then we fund a lot of staff training, from things like, I've got a couple of people doing PhDs, research into very specialist clinical areas, but also the very simple and very important things, like a lot of our reception staff get British Sign Language training, which the charity will fund, as Derby has such a big deaf community, and we're very keen to play our part in making our services accessible. So I'll stop there. I just wanted to give you a flavour of some of the things the charity does. I know many of you will have supported us today by buying some raffle tickets for our lottery. That funds the free tea and coffee for our staff. It's also funding at the moment Christmas presents for every patient who's in on Christmas Day. We took delivery of those Christmas presents yesterday, and my team have spent today giving them out to the wards. So they're ready for Santa on Christmas Day, as a small gesture for those people who are in with us on Christmas Day, to try and help make a difficult day a little bit special where we can. So thank you for your time, enjoy your evening, and I hope to see you in other events where we can support you further in the future. Thanks, Val.
Good evening, everybody. I'm Dr. Lakshmi Narayan. I'm a rheumatologist. I work in Burton, and I also lead rheumatology department for UHDB. And thanks to Val and her team to give me an opportunity to come and talk to you today, and for all of you to come and attend the talk. I was asked to talk about fibromyalgia and polymyalgia, and both are entirely two different conditions. So I will split them into two parts, and my first main part will be on fibromyalgia, and then I will spend a little bit of time on polymyalgia at the end, and then you also have opportunity to ask me questions at the end. I may not be able to answer every question you have on your mind. I am very well aware of that. And if you have any individual personal problems, I may not be able to answer them either. So it will be more a broad brush approach and what I understand about these conditions. And you may get some benefit how you can help you, yourself, your loved ones, because both conditions can be affecting younger as well as older people, and maybe a long-term condition. Okay. Hope it works. Not very good. Is that the one? Yeah, thank you. So first of all is fibromyalgia. As I mentioned in my title, is it in all in my head? So that's the question many people ask me, because if you go to a doctor and they make a diagnosis and they may say that, well, all of your tests are normal, there is nothing wrong with you, maybe one of the explanations, then it makes you wonder, am I imagining all these things? Am I somebody who is just an actor? So that is a kind of idea which may go through somebody's mind. So that's the title of my talk. And I tried to demystify some of the conceptions around it today. So I'll cover it by looking at definition, what all the things which can trigger this condition, and why this affects people, how we come to a conclusion at the end, how we make a diagnosis, and what is there to manage this. So those will be the broad headings I will cover. So it is a chronic condition, fibromyalgia, and it's what we call as a non-inflammatory. So I'm a rheumatologist. So what I understand as a rheumatologist is there are immune-related inflammation, and there are conditions which are not caused by inflammation but may cause a lot of pain and suffering. So fibromyalgia is one of the conditions which is not driven by inflammation, and it is a diffuse pain disorder, and it causes widespread pain in muscles, joints, spine, and different parts of the body at the same time. So we manage these in a different way compared to conditions what we would manage with an inflammatory condition. For example, rheumatoid arthritis, you might have heard of that, where we give immune modulating treatment to help people, whereas this is entirely different. So it's common in women. You may see that there are more women in this audience compared to men. It affects people. It may affect any age, though it's more commonly we see in clinical practice in middle-aged women, which may start in 30s up to 60s. We rarely see people above 60 coming for the first time with this condition. They might have had it for a number of years, and it may be diagnosed at a later stage. We also see some people in younger age group as well. So it's not, we just don't look at somebody's age and say, oh, you don't have it or you have it. It's fairly prevalent, which means 1 to 3% of Western world population has this condition. So in a group of 100 people, you may have 1 or 3 people who have this condition. if you are going and attending a party or something. So what triggers it? Because one of the things which people ask me is, what caused this? I have this condition, you made a diagnosis. What is the reason I got it? There may be multiple factors, and we call them as triggers. And it could be a trauma, a physical trauma. So somebody who has had a road traffic accident maybe, or had a fall, or they may have had a serious illness requiring them long hospital stay. For example, I get to see some people who had bad infection. They spent months in hospital or in ITU and then come out with symptoms which are what we later on diagnose as fibromyalgia. You might have heard post-traumatic stress, and people with this condition also develop symptoms of fibromyalgia. It could be not necessarily a physical injury. It could be even abuse in the childhood or in adulthood, or it could be something related to the mental stress. So there are a variety of things which trigger it. As I mentioned here, infection and stress. I mentioned impaired sleep. I'll come to sleep at a slightly later stage because there is some research evidence how sleep can be one of the triggers. And family history. So why family history? So there are genetic studies which suggest that there are changes in the genetic mutations, and some people with certain types of gene mutations have impaired pain processing, and that can lead to chronic pain. However, we can discuss that a little bit later in some details. You also see that it can be overlapped, a lot of these symptoms, with other conditions. So people may have other symptoms, may not be just pain. So they may have sensitization to different type of food items, chemicals. So they may have something called as a chronic fatigue syndrome. So these are something we call as a spectrum of disorders. So at one end, you may have predominance of symptom which is classified maybe chronic fatigue, where fatigue becomes the major issue. Pain is not a major issue there. And whereas fibromyalgia at the other end of spectrum, pain, sleep impairment, and fatigue become the predominant symptoms. So you may have people in that spectrum disorder in various different types, and also they may move from one end of the spectrum to the other end during their lifetime. So they may all be clubbed, and their symptoms, a lot of their symptoms can be attributable to certain explanations, which I'm going to discuss in a minute. So what are the common concerns? You may identify most of them because some of you may have these symptoms. So it's widespread pain, which is what people get referred to our clinics. And sometimes they say that I get swelling in the joints, and the doctor who examines them says, oh, you don't have swelling. And is that something then they are imagining or making it up, you may ask. But there is subjective sensation of swelling in muscles and joints, which may not be obvious to the person who is examining it. Okay. Fatigue. So these are the three main things which people come to us, and most of them will have impaired sleep. So they may say that I can't get to sleep, or if I sleep, it's always broken and it's always unrefreshing when they get up in the morning. So those are the different patterns of sleep impairment. I was just having a quick chat with the fibroactive group outside. So yes, they have, and we're having the same chat about what symptoms and how they manage. So brain fog remains one of the major symptoms which people will come and tell me. So we call them in medical term cognitive impairment. So you can have short-term memory impairment. You may not be able to find a right word when you're having a conversation with somebody. Or you may go into a room and you just forget why you're in that room. I can't remember. Then somebody has to remind them as small things. It's not like a condition like Alzheimer's. You will eventually remember, but the thing is that for that moment, you may not be able to recollect what you want to say or what you want to do, and that can cause a lot of frustration. Unable to concentrate on any task you're doing, and difficulty if there is some complex task, it's difficult to perform them because you're not able to concentrate, or you may not be able to remember each step how you want to go about it. That can be a cognitive impairment, which is many times seen with fibromyalgia. And you can increase sensitivity to a lot of different sensory stimuli. So light is one of the common things, not able to look at bright light. So a lot of people wear dark glasses. I can see some people wearing glasses in this room. Or hypersensitivity to sound. So they can't tolerate high-pitched sound or loud noises. Even touch, we find that when we touch, somebody jumps out of the bed or the chair as if something is very painful. So variety of different sensation may be amplified and then become intolerable. So that is another thing. So these are the multiple different symptoms. I'm not clubbing everything here, but that can give you a clue what a person might be going through. If somebody has all these symptoms, you can just imagine how difficult it is to carry out their daily activities or live a productive life. I put this here because a lot of these symptoms, they can be leading into a vicious cycle. So somebody has got chronic pain. Let's take an example of somebody who's got back pain. So when they have pain all the time, it produces spasm in the muscles, because a primitive reflex is pain is a primitive reflex. And when we get pain, we imagine that, or we understand that it is due to some injury. And when there is injury, to minimize the injury or to aid the healing process, the brain tells the muscles to hold those areas which pain comes from tight. So the muscles go into overboard and they cause the spasms. And if you have, I give this example to some of my patients, that if you are holding a half a kilo bag of sugar in your hand for half an hour, what will you experience? So your whole arm will start to pain. So just imagine if you have back pain and your muscles are tensed 24 hours a day, how much pain it's going to cause on its own and how much discomfort it's going to cause to you. And that is one of the things which we see with pain, because I just gave you an example of back pain. It may be pain in the arm or pain in other parts of the body, which can cause similar kind of response to the muscles. And when you're in constant pain, you're worried something is going wrong with you. There is major injury or major damage, so that puts you under a lot of stress. And when you're in stress and when you're in pain all the time, it's going to affect your energy levels, even though you may not be doing anything, but it does play on your mind, and it also drains energy from your brain and makes you fatigued. And you may be taking medication for pain relief, it may not be working well, and you are not sure what's causing all these symptoms, and that makes you very frustrated. And that frustration turns into anger, and you're also under a lot of fear, and that may spill over and cause a lot of stress to you and also to people who are around you, not just you. So it doesn't just affect you, it also affects people who are near and dear, and sometimes relations. And when this goes on, when you feel that you are out of control, then it can lead to depression. And then again, it is like a vicious cycle. One leads to the other and amplifies all the symptoms. So that sustains the symptoms and drives the whole condition. So that's just a picture, the explanation of some of the symptoms, why they go on. And when you have these symptoms, you probably will go and discuss with your doctors, and they may do lots of tests, and then they may come to a conclusion that it could be fibromyalgia. So who can make fibromyalgia? So we get a lot of referrals into our system saying that this person has these symptoms going on for last 3 years or 4 years. do you think it's fibromyalgia? So most of the referrals which come to us are from general practitioners. So, or they may be able to make a diagnosis, but somebody may be telling them that I don't believe you. I want expert opinion. So that may be the reason. Or they may not be sure, something serious going on, so they refer us. Are they able to make a diagnosis? Yes, they are able to make a diagnosis. Rheumatologists make a diagnosis because most people end up in our clinic. Experienced physiotherapists can make a diagnosis because they deal with a lot of musculoskeletal conditions, and they have done that over the years, and they are quite capable of making diagnosis. But then they usually ask help from a doctor, and either GP or rheumatologist. I firmly believe this could be the diagnosis here. Are you happy to just confirm it? So there are 3 different places you can go to get a diagnosis. But is that the end of it? It may not be the end of it, but at least it will give you explanation to some of the symptoms. So after this section, I'm going to say why these symptoms come up and why they persist. So I don't want you to get overwhelmed by looking at this picture. This is just to tell you that there is scientific explanation for the symptoms, and just to give you a brief idea why the symptoms go on and go on. So you can see this is there are 2 arrows here, brain and pain, driving each other. So you could say that they are driving each other mad. Okay. So what actually starts the symptom? So to understand that, we need to know what stress does to us. Stress is a response which is for any kind of stimulus which we may not be used to. So suppose if you imagine that a tiger walks through this door. So we will have a fright reaction to that. So what drives it? So we got 2 different systems in our body. One is what we call as the autonomic nervous system, and that delivers adrenaline and noradrenaline, 2 different types of hormones predominantly, and that causes the fright response, which means you have muscle relaxation, you got dilated pupil, you start sweating, your heart starts racing. All these reactions, what you experience when you are scared, is driven by adrenal and noradrenaline function. However, when they drive this function, there is also another response which helps to make sure that that response is brought under control when that stress reaction or the fear is taken away. So we have that mechanism in our body. Okay? And there is another system called hypothalamic pituitary adrenal axis. So hypothalamus is part of the brain which is deep inside, and then that connects to a gland called pituitary, most of you probably know, which lies under the floor of the brain. And then there are adrenal glands just above your kidneys. So they're all 3 are linked. So when there is stress, hypothalamus releases some chemicals which stimulates pituitary to make another chemical which helps the adrenal gland to produce cortisol or steroid. And that cortisol has similar function which helps in addressing stress and making sure that we have appropriate response when we need that stress response. We all need stress response because it's protective. And you can see that stress response available or present even in lower animals as well. It's not just in human beings or well-developed animals. And when that cortisol is produced, this cortisol again gives signals back to the hypothalamus saying that, yes, we had the response, stop producing extra chemicals now. And so that's a feedback mechanism. So that's how a normal person or the normal hypothalamo-pituitary axis, normal autonomic nervous system supposed to work. Okay? There is evidence that if somebody has got chronic pain or they are under a lot of chronic stress for a variety of reasons, these protective mechanisms which calm them down are impaired. And when they're impaired, what happens, we'll see next. Okay, so this is the hypothalamo-pituitary axis. You can also see that CRF, which means it's a chemical produced by hypothalamus. It also works on some of the nerve endings, and you can see that it is sending the signals back up to the brain, which gives them the sensation that there is pain and what to do, and then there is negative feedback, what we call, from the brain to say that calm down now. We had the enough response, shut it down. So that's what should normally happen. So what happens in the people who are oversensitized? So there is repeated trauma. So we talked about post-traumatic stress of a variety of reasons. We talked about the stress due to a physical injury. So the feedback mechanism, you can see this is there a pointer in it? The red button? Yeah. So you can see this is the empty thing. So that is, if we go back to the previous one, you can see the purple feedback, which stops the whole cycle to shut down. Whereas this is now, that response has gone. And that means you have constant stimulation coming from the system down to the adrenal cortex to produce more and more steroids. And also, there is increased stimulation of the nerves, which are pain-sensitive nerves, to produce extra signals going back to the brain to say that there is pain, even though there should not be. And there is blunted response from the brain to shut it down. Okay, so this regulation is completely lost, or it is dampened down. That leads to the whole cycle of pain. And then we spoke about how pain itself causes different aspects of the symptoms. Now, coming to the sleep impairment, I told you about, I'll talk about sleep later. That's because you may say that pain affects my sleep. But the theory is entirely, you turn it over its head. It's actually sleep impairment many times affects the pain rather than the pain affecting the sleep. So there is evidence to support that. So if somebody has got chronic sleep impairment, you get people who have insomnia for a variety of reasons. There are people who have sleep apnea, so they don't get refreshed sleep. In those people, the response which I showed you in the earlier slides is always blunted. That leads to chronic pain status. So it's not necessarily the pain which affects the sleep. It's other way around. Sleep impairment actually can contribute a lot to the pain, ongoing pain. And then that leads to, you can see that one amplifies the other. So you can see they're winding up each system and amplifying the whole symptomatology, what we see in fibromyalgia. And there may be some chronic medical conditions as well. We do see that sometimes which can contribute to it, because we know that some people with inflammatory conditions, for example, have got association with fibromyalgia. And going back to the sleep impairment, we also know that when somebody is not sleeping well, it actually affects various different chemicals which are helpful in mounting an inflammation response. Their level goes up as well. So that, again, is another reason why sleep impairment causes more pain. Okay. So can you understand how do we make a diagnosis? One of the things which commonly used is what is called as a fibromyalgia rapid screening tool. So you look at the symptoms. So you have all these symptoms which you assess and make sure that there is no other cause for these symptoms. And then if there is enough criteria, then you can come to a conclusion that it's likely to be fibromyalgia. However, we just don't rely on just the symptoms. We do a detailed clinical examination to make sure that all the systems are perfectly okay, and there's nothing abnormal with those systems to explain these symptoms. We run a few blood tests as well to make sure that we're not missing something which we cannot be sure about just by listening to symptoms and also by just doing an examination. So And the next picture will show you that you might have seen that people talk about trigger points. So there may be plenty of trigger points, but we don't just rely on trigger points. If there are widespread pain affecting various different regions, and if there are enough numbers, multiple areas affected, then it is an indication that that person has fibromyalgia. So that comes, hopefully I've given you enough evidence to say that it's not necessarily what you imagine. It's actually, there is a scientific basis for symptoms, what you experience when somebody has fibromyalgia. Okay? So what's there to treat? Okay? Do we have a specific medication? That's one of the commonest questions asked to me to any doctor when somebody has got fibromyalgia. I can understand the frustrations and the problems it has caused in somebody's life, and everybody wants an easy fix, and probably a fix which can be done by a medication, and it goes away, takes away all the symptoms quickly. Unfortunately, we don't have that magic fix. And that's what I tell everybody in my clinic. Usually I'm honest with my response, saying that if you want that one, I'm really sorry, I can't offer you that. People may become a little bit frustrated, disappointed, and they are right to have those feelings. However, what they need to understand is what I'm going to talk now. Okay? So you can divide treatment into non-pharmacological, pharmacological, and referrals. Okay, what are the non-pharmacological symptoms as ways to manage it? So the cornerstone of fibromyalgia management is self-management. So I'll come to what are the different aspects of it in a minute. Everybody should have an identifiable goal for themselves. What do they want? Because know that they have the condition. What are the expectations? It's true for every condition we treat. So if somebody comes to me with rheumatoid arthritis, I ask them, what exactly you want when we treat you? Because we need to tailor the treatment according to the needs. So a person who is in their 20s or 30s may say, I want to run marathon. And somebody who is in their 70s may say, I just want to go without pain to my shopping every day. So the needs are different. So you need to understand your own need, what you want when you want the treatment, and then you tailor that treatment according to your need, and you keep that goal to achieve. And when you have a goal to achieve, it may become a little bit easier. So main treatment which we need to focus is pain management, because it is one of the commonest and the driver of a lot of the symptoms. So that's what we'll talk about a bit. Exercise therapy and something about mind over matter. So first of all, I spoke to you about sleep, why sleep is important. So addressing sleep abnormalities would be one of the major aspects of treating fibromyalgia. So when people come to our clinics, we have a referral system to our physiotherapy department. And what do? They have an education session for people with this condition. And one of the major things they talk to them about is sleep and improving how one can improve the sleep. So it could be something called a sleep hygiene. So what is sleep hygiene, you might ask? Some of you already know, some of you may not know, so that you have to have a fixed time to go to bed. You can't just randomly go late to bed and expect that you will have a normal sleep cycle. Okay? So you have to fix the time, and you have to make sure that your room is colder. It should not be warm. You have a nice pillow. You have to make yourself a little bit warm with blankets or something. Make sure that the room is dark. Don't use your electronic equipment about half an hour or at least before you go to bed, so that your mind is calmer. And make sure that you're clean when you go to bed. Okay, so those are some of the fewer elements, essential elements, how you can help you to get to better sleep. And then you may need sometimes medication to help you to sleep, but that depends whether you would like to go down that route or not. By improving your sleep quality, then you can see that I spoke about inflammation mediators becoming abnormally high if somebody has got sleep impairment. So you're reducing those levels. By reducing the inflammation levels, you can also then help the pain. So that becomes one of the most important factors in the management. Second is relaxation techniques, and exercise. So what exercise one can do? Can somebody go and join a gym and do weight training and things? I told you about having a realistic goal, and what you can expect is very important. So you may not be able to go and work out in a gym for 20 minutes or half an hour in the beginning. There are people who have run marathons and have been very fit people who may develop this condition, and they may want to go back to that as soon as possible. That may be possible at some stage to some extent, may not be to the full extent what they did in the past. However, it takes a long time. So the patience is the key. And the exercises they may have to go through to build up the muscle function are multiple, different ones, because not everything is like you may want to go for a swim. And not everybody I spoke to in clinic would like to go to swimming pool. So the idea of exercise is different for different people, and it should suit what their need is and what they like, because you need to enjoy that. Unless you enjoy, you may not be able to pursue it or persevere it, so it may not be very helpful. Swimming is helpful because you are in warm water. It relaxes the muscles. It takes away your body weight. And so you may start with walking in the warm water, and then may start slowly doing exercises in the water and then swimming. Tai Chi is one of the other things which many people find helpful. One of our physios actually runs Tai Chi classes in the community in Burton, and I spoke to fibroactive people who said that they also use Tai Chi training in their program. So it does help. Yoga, these are gentle stretching exercises. Some people use Pilates as well. So there is not a single type of exercise which may be helpful. One of the common things people tell me is that, I went for the exercise, but it was causing too much pain. I had to stop. It is going to cause pain in the beginning, but if you start slowly and build up your exercise capacity, you'll be able to do more exercises, but it may take sometimes 6 months, maybe a year or longer, because you had the symptoms for a number of years before you have seen a health professional. Don't expect it to go away within 3 months or 4 months. And that's the other thing. Another one is mind over matter. I spoke to you about meditation. So how meditation helps? So meditation helps to calm the mind. A lot of the people, when I talk to them and tell that, my mind is in an overdrive when I go to bed. I can't relax. So mind can help, the meditation can help to relax the mind and can help in relaxing the muscles, relaxing and helping to go to sleep and get sound sleep. That's one thing. And there is enough evidence to say that when somebody does meditation, it does help in reducing the adrenaline and noradrenaline levels. Their pain perception improves, and the unpleasant sensation the pain gives is dampened down. So it does have scientific basis for that. So how do we know that? One, because there are newer imaging techniques called functional MRI. So they did these functional MRI studies on people who had done meditation, who have not done meditation, and they had all suffered from chronic pain. Then they found that people who actually practiced meditation regularly had different perception to pain, and the activity in the brain in the areas where pain perception is high was dampening down. So it does prove that meditation is of some importance. What about the other things? Some people may not like meditation. I come across people in my daily, it may not be work, it may be even in my daily acquaintance. Not everybody does meditation. I don't blame them. And it's not one treatment which fits all. Music is helpful because it does help to relax the mind. People have used acupuncture and heat therapy, cold therapy. So all those thermal therapies is of benefit. People can also use aromatherapy. So whichever helps to calm the mind will be helpful in the long run. Education, understanding about the condition. So one of the things people think that when they have painful condition, there is an underlying tissue damage. Whereas this is a condition which is more of a nuisance. There is no damage to the tissues. Pain is not an indicator of damage here. So if you do exercise or if you do physical activities and if it increases pain, it doesn't mean that you're causing more damage either. So understanding that, understanding the whole process of the condition, why people get symptoms, what drives it, and addressing various elements of those drivers, which is always helpful. And we talk about talking therapies, including cognitive behavioral therapy. That is very crucial for many people to understand their traumas, process the trauma, and also to manage the pain. So it has got various aspects. It's not necessarily how to learn to manage pain. It's also about the trigger which initially probably has caused it, going back to that and processing that to come to terms with that will also helpful in the long run. So I talked about most of these non-pharmacological approaches to treatment. So can you avail that in NHS? Some of them it's available, some of them it may be difficult, there may be long waiting times to access them, and it's a frustration for people who have the condition, people who treat the condition like us as well. So there may be lots of resource restrictions here, so that can be a limiting factor. In those instances, what other help is available? So there are patient help groups which you can have access to. You can talking to people who have the same condition, how they have managed their symptoms, what tricks they can learn from it is also helpful. There are web-based and application on the smartphone-based solutions for mindfulness. There is one app called Headspace, which I can think of, which you can use to learn meditation and relaxation techniques. And there are web-based applications also to help you with CBT. And I'm telling about Fibroactive again because I had a chat with them and they run courses, which is partially funded by different agencies. So you can avail the facility of these patient groups which run the helpful training programs. Because they can give you lots of tips how to manage your symptoms. It's not just the exercises, they also have the diet approach to it, and understanding the mechanisms and various other aspects of management of fibromyalgia. Physiotherapy, we definitely send all our patients to physio groups. And they, apart from the yoga and Tai Chi and Pilates, they also can give you some ideas about different techniques you can use on a daily basis to help the symptoms. You can go into leisure centers. A lot of the leisure centers now run Pilates classes. They also have yoga classes, so that might be helpful if you start from the novice, so you can build up your exercise capacity. So it's not just necessarily everything in the hospital or through your GP. There are other avenues which can be availed. which I think was very essential. I'm not going to talk about the tablets because tablets are the last resort, and I don't think they are the best approach to manage the fibromyalgia. If somebody is in a lot of pain, it may be a temporary measure to help to go through that and to dampen some of the symptoms to avail and practice the other aspects I just talked about. That comes to the end of my fibromyalgia talk, so I'm going to spend a few more minutes on something called polymyalgia. It's entirely a different condition, so there is no link between fibromyalgia and polymyalgia, even though they may sound similar. Polymyalgia is a condition which is driven by immune system causing inflammation in the blood vessels all over the body. It predominantly affects people above 60. We rarely make a diagnosis in somebody below 60. And we don't see this condition anybody below 50. So it's not something, if somebody has symptoms which may sound like polymyalgia, but if they are younger than 50, it's not polymyalgia. That's the rule of thumb. And no rheumatologist would dare to make that diagnosis below the age of 50. Okay. What are the features? So I think there is a reason why I was asked to talk about polymyalgia with fibromyalgia, because you may feel that the symptoms may be similar because it causes pain, it causes stiffness, and because of pain and stiffness, it affects sleep. Unlike fibromyalgia, where impairment is the driver of the pain, here actually the pain is the reason for sleep impairment. So it feels like the classical symptom some people tell me, and most often it gives away the diagnosis, is that I feel stiff like a board. I can't turn over in the bed. I can't get into the shower, or I can't get into a bath. And I can't get out of the chair. It suddenly happened, it happened over a few weeks' time. I just got some pain around shoulders, and then I wasn't able to lift my arm. I couldn't wash my hair, or I couldn't even get dressed. So those are the typical symptoms. And when we do blood tests after examination, we see that inflammation tests are abnormal. So we do two tests called ESR and CRP. We do both of them, and they are abnormally high. You don't see those tests abnormal in fibromyalgia, but in polymyalgia they are high, suggesting that immune system is actually in an overdrive causing inflammation. Okay, so those are the major differences: the age, the symptoms, and the abnormal blood tests. And is there a treatment? Yes, there is a treatment in terms of tablets. Okay, so unlike fibromyalgia, you can give these patients prednisolone tablet, and they respond really well, and it gets a dramatic response. So if I see them after 2 weeks, they will say, oh, after 3 days, I'm back to my normal self. So that's the usual response we get. So that's, again, this is something which is targeted treatment and quick response, which is unlike fibromyalgia. So if you have anybody in your family who is about 60 and develops these symptoms, take them to doctor straight away, because there is an inflammatory response, and a quarter of these patients may develop something called giant cell arteritis, which may affect the vision at some stage if it is not picked up quickly and treated promptly. So that's the urgency with this condition. Okay, so covered all those tests, and I didn't mention about scans. So when we are not entirely sure, because not everything is as clear as I say in medicine, and we can do some special scans. We resort to something called PET scan, which is a scan done in Nottingham, and which can give us an idea blood vessels are inflamed or not. Okay, so that's how we come to a diagnosis. And I just mentioned about treatment, medication, but this is an inflammatory condition which drains the energy levels down. Again, fatigue is another feature here. However, because people are older, to recoup that energy is difficult, and also they lose their muscle function to some extent. So we use help from our physiotherapist to build up their muscle strength, because some of these people may still feel physically not able to do things which they were able to do before this condition set in. So as important is tablets, and there is also an important factor for other aspects of treatment like physiotherapy. So that comes to the end of my talk. So I'm happy to take your question, and I hope I can answer some of the questions. If I'm not able to answer the question, then I will refrain from answering them. Thank you. Thanks for being patient with me.
Thank you. Thank you. Could you tell me, on average, how long polymyalgia lasts for? Is there a sort of an average time?
Most often about 2 years to 3 years. So the treatment we give is steroids, as I said, and we keep reducing the dose over a period of about 12 to 18 months. Some people get relapse in between, so we may have to go back to bigger dose of steroid and follow the same strategy of reducing it. Occasionally, we do see people who may need different medication to get them out of steroid treatment. And that is not the rule, but it does happen. About 15-20% of people may need longer treatment.
And how do you know if you're getting the giant cell arteritis? What are the symptoms of that?
It usually starts as sudden onset, one headache, usually on the one side of the head, on this right or left, and not on the top, usually on the sides here. And that's the commonest symptom. And people may also get pain in the muscles in the face when they're chewing food. We call as a jaw claudication. And that might indicate that they may have risk of developing problems with their eyes. So if they develop problems with the eyes, it may be double vision or blurred vision.
With polymyalgia, when you get to the end of the steroid course, is it quite hard to make the jump to really low to no steroids? Is that a phase that's really difficult for patients?
Some people find it difficult. That's predominantly because people who are in this age group also have wear and tear problems in their neck and shoulders. So steroid is not a specific treatment just for polymyalgia. It also helps symptoms from other conditions, and one of them is osteoarthritis or wear and tear. So when they're coming off steroids, those symptoms may become a bit more noticeable. So they may say that, oh, I'm getting the symptoms of polymyalgia back. And that's the role of the doctor then to see whether this is true polymyalgia relapse or not. So then making proper assessment and discussing the aspects of this with the patient and getting the help from other professionals to manage that would be useful than just pushing up the steroid dose. And we do check their blood test to make sure that inflammation levels are normal before we make that conclusion.
There's clinics in hospitals that do for ME, chronic fatigue syndrome. Why isn't there one for fibromyalgia when it's probably more widespread?
Because the constraints in the resources is the main thing. In rheumatology, fibromyalgia is predominantly managed by rheumatologists in a traditional way, like how it has been practiced. So we also manage lots of other inflammatory conditions. I just mentioned rheumatoid arthritis. We do manage ankylosing spondylitis, psoriatic arthritis, connective tissue diseases like SLE, other inflammatory conditions like polymyalgia. So there are so many other conditions we manage. So the time available to see patients with fibromyalgia is not great at the moment. And also, a lot of this treatment which you saw is non-pharmacological, which means we need help from allied health professionals who can help us. We have not got enough resources to employ them to deliver it. We are very well aware of that. We actually, in Derby unit, did a pilot project. So patients who were suspected to have fibromyalgia, those referrals were screened by a rheumatologist, and then they felt that they fairly confidently that it is a fibromyalgia condition, they would then let these patients seen by physiotherapist instead of coming to rheumatology clinic as the first port of call, and had their assessment and the treatment in terms of exercise program and things. So that actually helped to reduce the waiting times, and also in the long run helped to improve the outcomes in terms of patient feedback we collected. And we also worked out the finances, and it actually was much more cost effective. Unfortunately, we could not take it beyond pilot project because we were not getting enough funding to implement it in the primary care, because that's what is our aim in the long run. We want to work with the ICB and the PCNs to set up these assessment units run by predominantly physios, but supported by a rheumatologist to make sure that if it is not fibromyalgia and it's something else, then we can help in to address those issues. But then if it is fibromyalgia, they are effectively managed within the community itself. So it stops people coming to hospital. It also reduces the waiting time. So now our rheumatology waiting time is almost a year. At the end of the year, you might be coming to see one of the specialists in the clinic. And after half an hour, we say, this is your diagnosis. This is what your treatment. You are sending you back to physio. And then you need to wait. If you're going back into community physio, you may have to wait another 6 months again. So it is frustration for us, frustration for people, more frustration for people who have the conditions. We don't want people to be in that situation, but unfortunately, we don't have enough resources to implement what we want to do.
I think it's something that's needed, though.
Thank you.
Hello. I've been diagnosed with polymyalgia rheumatica. Is that connected with weight loss? I'm losing weight.
Initially, before the treatment, yes, it can cause weight loss, loss of appetite, because it's a systemic inflammation. So the chemicals which are produced during the systemic inflammatory process have similar effect on somebody who has got cancer. I'm using that C word because there is a chemical called tumor necrosis factor or similar chemical which is produced. There is an inflammatory response, and it has effect on the appetite. So it dampens appetite, then it reduces the weight. As a result of it, it also causes other symptoms like fatigue, malaise, like you have flu-like symptoms, and what we call as systemic symptoms, and sweating, fever. All those symptoms may be seen in some people. But we may not see all the symptoms in every person, but yes, we explore those possibilities.
Thank you. Thank you.
Hello. Can polymyalgia be misdiagnosed quite easily? And if so, is there a test to confirm it?
Yes, it is commonly misdiagnosed in the primary care many times because it is not a very common condition to start with. So not many people would have seen it unless they have worked in rheumatology. And the other thing is that because it starts with symptoms of pain and stiffness around neck and shoulder, you have similar symptoms which can be seen with spondylosis of the neck, wear and tear in the shoulder. So it can be easily misdiagnosed as polymyalgia when they may not have. And that's where the usefulness of inflammation tests will be seen. So if somebody has polymyalgia, invariably ESR and CRP tests are abnormal, unusual for them to be normal.
Okay. And can it affect your hands?
In some people, it does cause swelling of the hands in the initial phase, yes. So I'm not going in details about the different names. They have got complex names. Yes, we do see that from time to time. And sometimes rheumatoid arthritis itself may present like polymyalgia in the initial phase.
Okay, thank you.
Thank you. Just got another question. You mentioned that 25% of people are at risk of getting this giant cell arteritis. Is there a specific test for that if someone...
No, there is no specific test for giant cell arteritis. We use the same tests as we use for polymyalgia, but then symptoms are different, and we look for different signs when we examine which, and then after that, if we are not still sure, we do ultrasound scan of the arteries in the around the face and sometimes the armpits and neck. And still, if we are not sure, then we do PET scan.
Thank you.
Can I ask one?
Yes, sure.
20 years ago, I was diagnosed with fibromyalgia. 15 years ago, I got giant cell arteritis. Was diagnosed polymyalgia rheumatica.
Yeah.
I'm still on prednisolone. After 16 years, my ESR is quite normal. Can you have polymyalgia rheumatica and your ESR is nearly normal?
When you are on steroid treatment, it can be normal. And it suggests that it's under control. And
So
then
the
that's where we
steroids-
try to attempt to reduce the dose and take the person off the steroids, if
Right.
possible, yes.
Yeah. So I'll keep plodding on then.
Yeah.
It's a funny balance eating,
It
having
is,
that
yeah.
many steroids, but I'll carry on if the SR is normal then. Thank you. Personal questions, sorry ladies.
Thank you, Doctor. It was really interesting and educational. Couple of things. In terms of preventative perspective, generally speaking, how it could be prevented in first place or in early stage, what could be preventative measures you could think of or put in place to prevent further severity? That's on prevention.
Is that for fibromyalgia?
Maybe both.
Okay.
Yeah.
Yep.
And the second question is around efficiency and optimal pathways. So what you mentioned about almost a year waiting time, huge cost in the acute perspective. So what are the levers from system perspective as a whole system, how we can improve whole pathway approach end to end rather than in acute treatment moving into more community PCN level? What would be, from your clinical expertise, what would be best as an optimal pathway that would help in terms of channelizing patient and reducing hospital admissions?
Okay.
Thank you.
Thank you. Both are quite complex questions to answer, and there may not be an easy, straightforward answer for them. So I'll take your prevention measures as first one. Looking at fibromyalgia, so we have to look at the drivers. So what are the stress-inducing factors we are looking at in our general population, and how we can help people to manage that stress better would be one of the useful things to look at. And also it may require involvement of various different agencies to help these people. You talk about the physical abuse, which may be within the relations, or the child sexual abuse. So those are the drivers which may lead on to for a person to develop fibromyalgia at a later stage, or even other type of chronic pain condition. So in clinic, if I have enough time and if I explore where it all started, many times we do see that these stressors are the reasons where it all began. And managing them at the initial phase probably would be more helpful so that they don't go down the path of chronic pain condition. So that would be my approach for fibromyalgia. With regards to polymyalgia, I don't think we have a specific preventive pathway for that because it's an autoimmune condition and people have got a genetic preponderance to develop an autoimmune condition, but it's not all down to genetics. There is something called, as you know, epigenetics, which means there is something, environmental factor or other triggers which may be triggering people who are vulnerable in their genetic makeup to develop the condition. What I didn't touch upon in genetics and fibromyalgia, I said there is very tangible evidence to say that people who have certain genetic mutations have different type of pain perception and go on to develop chronic pain condition. However, not everybody with that genetic mutation will develop, but the reason behind that is, again, epigenetics. How every person responds to a stressful situation in the end decides whether that person is going to develop the condition or not. So even though genetic has got some answers why that person might be developing the condition, I don't think genetic screening would be of any benefit in both these conditions and will not be helpful in the public health perspective. So that's my answer to the first one. Second one, I forgot the second one, sorry. Improving the access. Yes, yeah. So I think we have proven to some extent with our pilot project that management in the community is much better option. Holistic approach with the involvement of various other agencies. You may have social prescriber, which Val was telling me about it before, that we can utilize their help in doing some exercise programs in the community or meditation training in the community, which will be helpful. Assessment based not within the hospital, but helping the GPs to access those services available in the community easily will be helpful. We have been working with the ICB in the Staffordshire for some months now with this idea of implementing chronic pain service within the community. And we do have a pathway to show them that how it could work. And in principle, the ICB agrees. But again, the priorities are different because they have got different pressures on them. So in the end, it comes down to the funding of the service. I think utilization of the community services, which may be voluntary organization, would be of much benefit because they already have certain things which they run in the community. Accessing those things, helping people to access them in a meaningful way would be another way of use of existing resources for improving the treatment for these patients.
Thank you, Dr. Laxamari. No, it's really great. You've given us a lot of information. It's all helpful, very helpful. So thank you very much for giving us your time this evening. I'd like to thank as well Ross, Alex, Amy, Pip, and all the crew that have helped set up today. Put a lot of work in the background. And thank you all for coming tonight. Have a safe journey home. If you're in car park 5, just press the buzzer, say you've been for one of the talks, and they should let you out. There'll be no charge. Hopefully. So thank you all for coming.
Thank you all for coming.